relatively small losses in bone mineral density for the individuals that went on to suffer a fracture. And there's some changes in geometry. We talked about bone mineral density being higher for the diabetics than non-diabetics. And here we see that distribution of density. So this is comparing, in all of these, we're using the control no fracture group as the basis or the reference frame. And these are the type 2 diabetics that did not suffer a fracture. And they've got this increase in density along their trabecular cascade. And now finally we look at the type 2 diabetics that did suffer a fracture. And we've got these big changes in geometry in terms of, so shafts are different, or shaft diameter is different for one thing. It's pretty clear to see between those that suffer a fracture and those in the control group that don't. We still have an increase in bone mineral density along the trabecular cascade, but we've got decreases in other places. And so this is, like I said, this is early work, but it's going towards, and the other thing I can say is that there are a set of composite traits that identify those that are diabetic versus those that aren't. And there are a set of composite traits that identify those that suffer fracture versus those that aren't, or that don't suffer fracture. And then finally there's a group of traits that describe that interaction between them, individuals that go on to suffer a fracture with diabetes versus those that don't. So again, we talked about diagnosis for the most part here, and now I'm going to move on to therapy briefly. So when we get a better understanding of who's at risk for fracture and why they're at risk for fracture, then we can move towards trying to understand how to treat that specific individual. So the question is, what do these composite traits mean? And sure, so on the left, you've seen both these plots before. This is a cumulative explanation of the total system variance in composite traits. And these are the composite traits in red, are the ones that were selected in the statistical shape and density modeling based predictor as being indicative of those that suffer a fracture and those that don't. So they're combinations of geometry and density, or traits, and relationships between those bone traits. But the question is which combinations, and then how can we use this information to understand the individual. Excuse me. So this is a little bit different plot. So here we've got these combinations of composite traits. And typically in statistical shape modeling, statistical shape and density, trait modeling, whatever, you take the set of composite traits that describes some large proportion of the total variance. So say the first 53 describe 90% of the variance. So we'll look at those. And what this is showing, so here we've got, in orange, we've got all of the weighting factors that individually describe more than 10% of the total variance in the system. So those three describe 47% roughly. The group in green are all the weighting factors that are greater than 1% of the total variance individually. So now we're describing 52.3, and that gets close to the roughly 54% for all of these red dots that were selected. But then we've got this group way down here at the tail end, and all of these weighting factors describe less than 1% individually, and cumulatively, the 15 of them only describe 1.5% of the variance in the system. So they don't describe a lot of difference, but some interesting things happen if we build a couple more fracture prediction models. So this is SSDM and age, weighting factors and age, and we've seen that before, so that's the best one. Describes 50% or 55%, can accurately identify 55% of the individuals that go on to suffer a fracture. Again, these numbers aren't that different, but now we're looking at all of the weighting factors that are greater than 10%, so there were 3 of them, adjusted by age, and we go way down. So describing 47% or describing 53% of that variability doesn't do nearly as well as including all of them. And if we look at those composite traits, the 15 composite traits that by themselves only describe 1.5% the total of the cumulative variance, or the variance in the system, these describe 40%, 38% of, or accurately classified 38% of the individuals that go on to suffer a fracture. And it ends up being kind of interesting that this classification rate is not statistically different than that one, but these two are very different, and they're statistically different. So we talked about complex traits. So what are the differences that are carried by these individual shape modes? These plots are, these fringe plots again that we've seen, but this is all 53%, the 24 roughly variables, I think it's 24, something around that, 22 maybe, that were selected in terms of composite traits adjusted by age. And so we see these big differences again in terms of the fracture, the mean fracture femur versus the mean non-case femur. So big differences in shape, in size, and then we've got these same big differences in density distribution. So, but again, what happens if we look at just the 20 composite traits, or composite traits that only describe a small percentage? So here's that 1.5% of the total variability, and there are much smaller differences between the femur fracture and the non-case fracture, or the non-case femur. Smaller differences in terms of geometry and smaller differences in terms of density. The other thing I didn't point out, but that's not a big, even these red regions that are at the end of the scale, that's not a very big change in density. And so what this points to is that maybe we don't need huge, big changes in a person's bone in order to affect change, right? We need to target how we change the person's bone. And if we only have to make small differences, whatever, 0.08% or 0.08 volumetric BMD changes between the individuals that suffer a fracture and the individuals that don't, and we put that bone in the right place, maybe we could go about it that way. So, how do we determine what the optimal treatment plan is for the individual? We've got pharmacological approaches. There's some stem cell work that looks like it's leading to bone formation. There are things you can do in terms of exercise and yoga. There's a study where people did 12 minutes of yoga for 6 months and ended up with more bone mineral density than individuals that didn't. There's a study of a group of old men that hopped on one leg in England. And just by hopping on one leg, aside from the risk of them falling over and breaking another bone, I guess. But just the fact that they hopped on one leg led them to form more cortical bone density, thickened cortical bone on the leg that they hopped on. The interesting thing is that it's some systemic response. So maybe it's inflammation, whatever. But so they got definite increases on the leg they hopped on, but they also got increases on the leg they didn't hop on. So, so there's some systemic thing here going on. And there's also, I mentioned if you don't fall over, if you do better with balance, you're less likely to suffer fracture. We've got muscle condition issues. And so, all these things, the problem with them is that for the most part, 98% off the top of my head, all of these studies that determine efficacy of all these treatments are based on whether you increase mass or not based on where that mass is. So if we go back to the beginning, if we say that bone mass isn't a very good indicator of who's going to suffer a fracture and who's not, then there's a lot of uncertainty in whether these drugs or these treatments are really going to affect change in the individual or not. So we can move towards, once we understand this diagnosis, a means of diagnosis, we can start to move towards individualized therapy, and then we can move towards treating any individual in the clinic, and that's really where I want my research to go. So I talked, and I'm going to go through this quickly, I guess, but statistical shape and trait modeling or density modeling is a subset of that. We're describing variation in this multivariate space of geometry. We could consider joint alignment and other joint alignment of the knee. I've looked at that in other models. And trait distributions that are contained within 3D imaging data or any distribution of traits that you can measure physically. We don't make a priori assumptions about the importance of traits. We let the data sort itself out. And so these allow these investigations of the important structural differences, the structural organization that then can relate to functional outcome. Is a bone stronger or weaker? Does a person go on to suffer a fracture or not? And we can also tie in the molecular condition like I talked about. So what percentage of the variation in these these combinations of traits, composite traits, can be explained by levels of biomarkers or genetic expression, things like that. But in general, the method seems to be providing a means of improving the understanding of the important combinations of traits that lead to resistance of disease or injury. And so I showed you this slide before. Most of my work most likely will stay focused on the bone, and I'm moving towards the microstructure of the bone as well. But I also want to include, like I talked about, the whole body, and either in terms of functional outcome, whether they suffer a fracture or not, or in terms of whether their bone is strong or weak, and then tying that into molecular level characteristics of those individuals. I've got a number of projects that, so I was supposed to fit a bunch of things into this talk, and I'm struggling a little bit with time, I hope, or I guess, but I guess in the interest of time, this first project here, role of bone trait care variation and vertebral fracture resistance, is an R01 that I have currently. Year 4 will start in September of this year. And that's looking at trait variation, structural organization of 300 baboon lumbar vertebrae, and determining which ones are strong and which ones are weak relative to each other, and then how combinations of traits lead to the individuals that are strong or weak. And it also has a translational piece moving that towards, so 300 baboon lumbar spines and 30 human lumbar spines. So the goal is to map the knowledge from the baboon model to the human translational piece. I've got another R01, the role of composite traits in predicting vertebral fracture, that I submitted in June and came back with a 21st percentile score against a pay line of 12, so it wasn't funded, but the comments were all pretty manageable. A little bit of work here and there, and the plan is to resubmit that one, and I'm hopeful that that will get funded. Today, if everything went well, I'm partnering with another guy at the University of Texas Health Science Center. He's interested in diabetics, and I've been interested in diabetics for a little bit and the effects on skeletal fragility. NIDDK has a program, an R21 program, more money, 3 years instead of 2, the normal. And it's geared towards promoting diversity amongst new investigators. I'm not a new investigator, and I can't check anything but the white mailbox. So, but my colleague and my friend is a good guy and a good Hispanic guy, so I'm riding on his coattails. But it's work that we were going to do anyway, and it's interesting that that mechanism, it narrows the pool. So we'll see what happens, but there's a better chance of that getting funded than if we just went into the general pool. I've got a NASA grant pending now. It's looking at the risk of fracture in astronauts during dynamic loading conditions that might occur during launch or during when you board from lift, things like that. So these traumatic events to the spine, people are talking about, we're going to send somebody to Mars for 3 years, and whatever that company is wants to send them there forever. Whether that ends up happening or not, they're at risk for suffering a fracture. The general numbers are women after menopause lose 1% of their bone mass from their spine. every year. Astronauts, on average, lose 1% of their bone mass every month. So people are talking about these long-term missions, even the 6-month missions to the space station, for instance. The question is, what risks are these people going to be at because they're doing their job? And should we select people that are going to be at risk, or should we limit the people that should go into space because of their baseline condition? So that's my research side of things. I figured I'd talk a little bit about who I am. I talked a lot about what ends up being the lower category here, but I'm a mechanical engineer by training. At the end of the day, I'm a mechanical engineer, but I've always been interested in this type of work. Started with family reasons, continues with family reasons, but I'm at a point where I've accumulated a body of knowledge and I've developed collaborations, and I'm moving towards a direction where I think I can actually make a difference. To me, that's exciting. So I do a lot of work in computational modeling, primarily finite element modeling. I've done a lot of work in probabilistic modeling, whereas you have a deterministic model. You've got a model that each parameter, input parameter, has a single value. So whatever the number is, you have a modulus for this region. Probabilistic modeling is a framework where you allow there to be uncertainty or randomness in your input parameters. So you can, rather than a single valued input parameter, you can feed in a mean and a standard deviation, and then a distribution, statistical distribution for that parameter. And you can describe things like uncertainty, where you just don't know enough to quantify. So one example is the relationship between bone mineral density and modulus, or yield strength, or ultimate strength. Now you look at a regression, everything's regression based, right? So it's a nice, neat regression, except there's all this scatter all over the place. So these kind of probabilistic descriptions of variables allows you to take that distribution of error or randomness or whatever it is into account. And now, rather than getting a single valued output, like one stress level, you get a range of stress levels and the probability that's associated with each of those stress levels. So it's a much more powerful way of looking at things. And it goes a lot further than just assuming that everything you put in is right and everything you comes out has to be right, right? So it allows you to consider a lot of things that aren't normally considered. I do a lot of experimental investigation work. A lot of it's towards understanding what input parameters, distributions of input parameters to put into computational models. And a lot of it's in terms of validating the results of those computational models or simulations. My dissertation was in constitutive model development, and that's something that I'm continuing to work on. And then I've done this, this magic big data analytics thing. There are these huge sets of variables, and so big data analytics has this, it's a body of knowledge where you're reducing the amount of data into some manageable quantity, sets of quantities. And so, the shape and density modeling is based on that idea of variable reduction. And then I'm also developing classifiers to determine who's at risk for fracture and who's not, who's going to suffer a disease and who's not, things like that. So I do have some teaching experience, despite being in a non-teaching environment for 11 years. This past fall, I taught statics as an adjunct to some undergraduates down the street. Back when University of Texas Health Science Center is part of the University of Texas branch, medical system. University system, I guess. University of Texas system. Anyway, it's a medical school. And I taught musculoskeletal biomechanics. I lectured to orthopedic residents and fellows. Back when I was a case a few years back, I, all by my lonesome, taught kinematic analysis and synthesis, which I sort of gather is along the lines of dynamics of machines here. And then I've spent time I've got a few stories to go along with my dissertation, but I'll spare you those generally. Just I had experience, which ended up being useful experience, and bounced around in terms of being a teaching assistant or a lecturer in some cases and taking over more of the responsibility of the class as I continued on. But a lot of it's been in, well, it's almost all been in straight mechanical engineering, aside from talking to some residents that didn't want to look at equations at all. They ran screaming with the little bitty stress and strain things I showed them. And then, musculoskeletal biomechanics was a combined upper undergrad and graduate level class. So that's what I have experience in teaching. And in terms of what I might teach here, it's hard to gather what a course really is from a couple of words or a sentence about it. But I think I'd have a pretty straightforward time teaching dynamics of machines. Like I said, I think it's along the lines of the class I've already taught. I've got a lot of experience with advanced dynamics and principles of dynamics. I've got a lot of research experience with things that I would consider to fall under these classes. And then I've got a little bit of experience in machine design. I TA'd for a little bit, and there's a lot of overlap between things that I do and things that look like they're taught in these, in MEC 202 and 302, engineering design 2 and 3. In terms of, and so again, trying to find whether there's overlap between classes that are currently taught or not, but a lot of my work is in describing uncertainty and variability in modeling. So a class in that, incorporating probabilistic analyses methods in simulations and understanding what it means to verify a model, what it means to validate a model and different metrics for that. That's something I can teach in a pretty straightforward way. For the last 11 years, I've been working on, 10.5 years, I've been working on client-based problems. The client doesn't always know how they want to solve a problem. In some cases, they don't always know what the problem is. So I'm essentially a consultant in the position I'm in now. And so I think an interesting approach would be to develop a class where it's focused on my client has a problem, and it's your role. It would be a project-oriented class. There's some similar things, I think, in terms of designing something or a widget, for lack of a better word. But a lot of the work I do isn't designing things. It's in setting up an analysis or a model or an experiment, whatever. And so it's a little bit different take on that kind of class. And so here you can incorporate formulation of the problem, how to set up a course of action that you and the client both agree on, and then management of the project and deliverables. And there are interesting things like scope creep. If you ever get to industry, then that's one that you might see a lot. You've got this much money and your client wants this much project, and it's how to go back and forth and how to deal with things like that. There are various other problems that arise. And then the last class I have listed here is a musculoskeletal biomechanics class. There are classes that are called biomechanics. There's an orthopedic tissue biomechanics class. It seems, on the basis of the category or the course description, seems to be constitutive modeling sorts of things, but I didn't see anything that looked like it was whole body biomechanics. Build an open sim model, for instance, and look at what would happen if a person falls over, forwards or backwards or side or whatever, and how that affects the loads on their femur, for instance, how that affects the load on their radius. And then you can bring in things like what if they do have, well, in easy terms, less bone mass or less material, or a stiffer bone or a weaker bone, or a thinner bone, or all these things that we all have variation, and so if we fall the same way, we're fortunately all young. I guess I'm getting older than I used to be. More my hair's falling out than it did at some point, but the question is, how do we characterize the environment that people go through? If the little old lady leans over to pick up her grandkid, just because she's leaning over and putting her spine in an awkward position, and now she's picking up a weight, she's drastically changed the load on her lumbar spine. And if her lumbar spine is not in great condition, she's likely to suffer a fracture. So, with that, I apologize, I took a few more minutes than I was probably supposed to. I'm going to acknowledge some funding sources. These are the funding sources for the Mr. Oz work I showed you. I've gotten some internal research funding at Southwest Research Institute. This is the RL1 grant that I have now that funded some of this work. Some collaborators at Southwest Research Institute. Eric Orwell is the PI for the Mr. House program. Sandeep Khosla at the Mayo Clinic, I got data from. Thomas Link and Ursula Hellmeyer, and the diabetic data from UCSF. And Chris Kalchik, I haven't shown any of his work here or in this set of slides, but the work that I've done with him in terms of, so far we've looked at the effects of casting, immobilization, and then remobilization and exercise on a group of horses. You know, with that work, I've developed some of these techniques as well. So, I thank them, and I thank you for your time. For not throwing things. Yes?
So in the vertebral fracture example, did everyone suffer the same type of fracture, or like compression wedge fractures?
It's an interesting question. Don't know. So the interesting thing with these clinical studies is the diabetic one, for instance, they weren't even femoral fractures. So it's hard, you know, people are a terrible model. It's hard to get, you know, well, for one thing, people don't like breaking their bones, right? But, or they don't tend to. They certainly don't let you do it for them. But it comes down to the sample size. So in that group, so that was a study of about 700 men and women. There's 700 total. And out of that group, I was only able to get 80 where they were certain that they had fractures of whatever type in L1, L2, and L3. So I didn't want to do a study where I looked at, and that was L1 and L2. I didn't include L3 in the model. But I didn't want to do a study of differences in L1 and L2 that led to a radial fracture.
Oh.
So, I mean, some of the problem is in getting data, but it's a good question. With other things, you know, like the Mr. Ross study where there's a bigger set of data, this was only 450 individuals, and you know, the other part of it is you get this big group of, in that case, men, and you wait for them to suffer a fracture. I mean, that's how drug trials are based. You get this big group of individuals, and you hope they suffer a fracture, because otherwise you can't stop your trial. You don't have any measure of outcome, right? So it's kind of a backwards thing, but the goal is to look at structural organization and why, and you know, how that directly ties into mechanism. Even things like, you know, femoral neck fractures versus intertrochanteric fractures would be something relatively straightforward to look at. More time and more money.
So you haven't looked at kind of correlating your results to specific individual
I have not yet, but that's something that I'm very interested in doing, and I think makes a lot of sense, because that goes towards how you treat the individual, right?
When you do your principal component analysis, you know, that you described as unsupervised, and it kind of finds those important traits, is that like you write the algorithms that do that, or is this a package that you use? Like, I'm just trying to understand the tools a little bit.
There are some packages. The things that I've used, I've written, MATLAB. There are lots of different, you know, it's actually more prevalent now than it was when I started.
Right.
It just depends on the piece that doesn't exist very much, I guess. So there's some package code about similar models, but all the pieces don't exist in one neat package. There's some work that I did with another client. We set it up so that they could do their work on preclinical models in the same sort of. So it's generally packaged in a way that, I mean, certainly research level code needs a lot more validation, but my goals are to move it into the clinic, and I have some aims. I could talk about that, and I can talk about it later about how I do that. So.
Nice talk. So your composite traits, are those based on the population size or the population variance. I'm just curious, when you come out with these hundreds, all these traits, who knows how many you could possibly have? Then you narrowed it down to say 25. What is the rationale, say 25 versus 600?
Well,
traits?
So there are a couple of answers. One is that the total number of composite traits you get is 1 minus the number of individuals you have.
Okay,
So 450 individuals, 449 composite traits.
okay,
And then in terms of, so then you go, so you've got all these composite traits, and the question, and so far it's all unsupervised, right? You're not guiding it towards outcomes. But now you want to determine which of these composite traits tell you anything useful, or which combinations. So that's where the variable selection things come in.
okay.
So like a lasso algorithm, we used to have this line, some other S. And that's, so now you're bringing in the functional outcome, and you're determining which of those composite traits out of the total set will allow you to differentiate between one group or the other, fractures or not.
Gotcha, okay.
And then the test is to see if the whole group is similar, right? So you've got a training set where you're building the classifier, and then you've got this other group of individuals that the classifier knows nothing about, but now you use that test set to test your classifier, right? So in this case, it was a small 450 individuals. It's a relatively big number, but it's still small in terms of all the people that suffer a fracture. The other thing is these are generally white males. They're, community dwelling. They're not representative of the world, certainly. They're not, depends on what part of the country you're in. But, certainly variability, not all the variability that exists is being accounted for. Men and women weren't part of that study. Women weren't part of that study. So there's a lot more things you can account for, and so the question becomes, with each sample, you get different composite traits. And so with each sample, you get a different amount of variability, right? Because if you have 10 of the same person, it doesn't matter, you don't have any variability, you've got 10 of the same person. But if you've got 10 different people, now you're increasing the variable space that you're describing. And so, you carry that on. If you go to 100 people or 1,000 people, now you're describing more variability within that set. And so the odds of you describing some new person that comes in are much stronger. If I've got a model built on 10 people and somebody new comes in and I want to predict whether they're going to suffer a fracture, I don't know that I'm going to come anywhere near. I can force that individual to fit my model. I can map my model to that person. But I do a much better job if I'm describing a bigger variable space.
Yeah,
Does
that
that
makes
make
sense.
sense?
Yeah, it does. I'm giving you a tour tomorrow. We just
Okay.
started using tenfold cross validation for some
Okay.
stuff. It's an interesting topic that I don't understand, so
Okay.
I'd like to take some of your time tomorrow to talk about it too.
Yeah, sure.